Yes, sir. Good afternoon, sir.
Thank you, madam. Good afternoon. So, should we start? Only 17 students have joined so far.
Okay. So, shall we wait for 5 more minutes, sir?
I think so. Let us wait for another, 3-4 minutes so that
Okay.
more students can come and join.
Yes, yes, sir. Yes, sir.
Thank you.
Yes.
Dear students, is my voice clear to all of you? Okay. Uh, so thank you very much. Very good afternoon to all of you. Uh, Today we will discuss about a new topic, that is biomedical waste management rules. And to discuss this topic and to talk to you on various aspects of this particular topic, we have specially invited Dr. Sumita Soni, an eminent expert, from the field of biomedical waste management. And she is very much present with us in this online platform. So I would request Dr. Soni to kindly start her presentation without spending much time, because it is already 11 minutes past 3. Madam, if you are listening to me, can you please come online and start your presentation?
Yes, sir.
So thank you very much. On behalf of IGNOU Regional Center Bhubaneswar, we thank you very much for coming online to talk to the students of this most important topic. Thank you, madam. Please go ahead.
Okay, sir. Sir, is my slides visible, sir?
Yes, yes, it is very much
Oh,
visible.
okay, okay. So, very good afternoon to all the students of the CSCWM January 24 batch. And I'm glad to be the part of this, online platform for this IGNOU certificate course online classes. Basically, let me introduce myself. I am Dr. Sumita Soni, and I am working as an associate professor in Department of Microbiology at BJ Medical College, Civil Hospital, Ahmedabad. And I have written this learning center number 9174 because this IGNU course is going on in our campus at Government Spine Institute, wherein also I am working as the infection control officer in that institute. So, one of the very there are two topics which are assigned to me today. One is the biomedical waste management rules and its amendments, which we need to understand because it is a legal liability to all the healthcare workers and to all of us. Those who are, generating the biomedical waste, to those who are segregating the biomedical waste, and those who are disposing the biomedical waste. It's our legal binding to dispose the waste as per the legal framework of government of India. And for this matter only, the state government has also formulated the state pollution. All the pollution control boards are working on it, and state pollution control board has been formulated in each and every state, who is looking after it and who is basically who is certifying all these activities. So without the legal license, not certifying, even the licensing us, so without the legal license, a hospital cannot generate the biomedical waste. It's a punitive act, and we have to submit. As we are submitting the annual return, it will come in the month of, I think, in July. We need to submit our annual return. The same way, 30th June is the last day for submitting the annual return of the biomedical waste as per the biomedical waste management rules. So coming to the topic, all the waste which when we categorize it, we can basically classify it into the solid and the liquid waste as per the physical property. As per their hazardous property, we can tell them, we can classify them as a hazardous and non-hazardous. Okay, and in the solid, there are two type of the waste are there. That is a biodegradable and non-biodegradable. Again, as per the WHO, they have uh, classified the waste into the infectious, sharps, pathological, cytotoxic, and all. And as per the biomedical waste management rules of India, initially the biomedical waste management rule 1998 rules were applicable, wherein we were having the 10 categories of the waste. Now it has been cut short and made compacted so that we understand the mantra of the segregation, why to segregate, and it is all very much logically interconnected, so that the waste we are generating, it's all linked to its final disposal. And even if it is reused, it is reused, it is linked to its reuse policy also. Reuse doesn't mean that we are going to, if we are vacuum syringe and all, we are discarding in the red and it is reused, it doesn't mean that it is reused to prepare that syringe again. No, if it is a plastic material, maybe it is used for the road resurfacing and all. So this is how, so this word reuse has got a different meaning over here. Then the waste can be classified as per the source, that is the healthcare, agriculture, industrial, and the municipal waste. In the liquid, we can have the storm water, gray water, and the black water waste. So infectious word or the biomedical word is very, very important, because it includes the human waste, animal waste, and waste and object and the material contaminated with blood and body fluid, which can contain the microorganism or different type of the viruses. uh, Infectious waste per se is generated in a very low quantity, even in a healthcare organization. The entire, the concern is that we should not mix it with the general waste. If we are mixing it with the general waste, then that general waste, which is in the huge quantity, also becomes the infectious. That's why learning of the biomedical waste management is very, very important, and segregating it right at the source of generation is the key concept or the key mantra to fight against these, to reduce the hazard of the biomedical waste which is generated in a healthcare organization. So I have already spoken about it. So main thing is that we want to minimize the spread of the disease from the medical setting to the general public, and overall amount of the this waste also we want to reduce. So these are the two important fundamentals on which we are working, and hence this waste is regulated not only in our country, in other countries also. So it helps to protect the environment, reduce its amount in the medical facility, reduce the medical facility treatment expenditures also. So this is how it is linked. When we talk about the legal aspect of the waste management, so initially in 1981, Control of the Pollution and Prevention Act was there. Then Environmental Protection Act 1986 was there. Then hazardous waste management and handling, it was previously called as, in 1989. And in National Environmental Tribunal Act 1995 also has the legal framework for the waste management. Then came the Biomedical Waste Management and Handling Rules, that in 1998. And then came the Biomedical Waste Management Rule 2016 and its amendments. So after 2016, in 18, 19, and even in 20, the amendments has come. And in 20, the amendment was completely targeting and it was revolving around the COVID waste management. So when we talk about the biomedical waste, this rules, which was published in the Gadget, so it is about the previous biomedical waste management rule. So how it is different from the rule which we are learning right now. So it was published in 28th July 1998 by the Government of India, Ministry of Environment and Forest. Okay. To implement rules more effectively and to improve the collection, segregation, processing, and treatment, and make it more environmental friendly by reducing its in a sound manner and reducing its generation. Central government has reviewed the existing rule and then they made a big change. And that big change was really a huge change after 1998. After around about 20 years of this waste management rules, again a notification came by the Ministry of Environment, Forest and the Climate Change on 28th March 2016. And right now we are following Biomedical Waste Management Rules 2016 and its amendment. So it has been adopted and notified with the objective to stop the indiscriminate use disposal of the biomedical waste, and it should be handled in an appropriate manner so that it is not a threat to the human as well as environment. And then it basically important part which deals are the generation, handling, treatment and disposal of this waste which we generate in a hospital or a healthcare setting. So these rules apply to all the personnel who generate. So mainly when we say that the notices, when it is a legal liability, we need a license to generate it. So whenever the notice come, it comes to the highest authority of a healthcare organization. But the main responsibility, the onus is on the person who generates the waste. Okay, so the generator has to segregate right at the point of generation only. Then only we will be able to follow the biomedical waste management rules 2016 in a correct way, in a religious manner, and we will be able to prevent the human health as well as the environmental safely. So then generate, collect, receive, store, transport, treat, dispose and handle the biomedical waste in any of its form. So it has got certain rules. So rule 4, it is the duty of the occupier. It shall be the duty of every occupier to take. So first duty of the occupier is to get the license to generate it, and they have to ensure that biomedical waste is handled without any adverse effect in the human health and the environment in accordance with these rules. Then comes the rule 5, that is the duty of the operator. So this is they have got it has got a two part. So it is more related to the treatment and disposal of the biomedical waste which is generated. Then comes the rule 6, which is specifies the duties of the authorities. And rule 7 is about the treatment and disposal of the biomedical waste. 8 talks about the segregation, packaging and transportation and storage. So we will focus more on the rule 8, and that too on the part of the segregation, and if any pre-treatment needed on that part only. I think there are different lectures and settings which have been designed by Dr. Kuba madam, decided and defined by Dr. Kuba madam. So I will not be touching others areas. So I have to speak about the biomedical waste management rules 2016. So I will be sticking to that only. So it is rule 9 9 tell about the prescribed authority shall implement all these rules, and 10 is the process of authorization. Every occupier or operator handling it needs to get a get a license to license or authorize. So it is called as a consent to authorization. And how much quantity, how many bedded they are, that the state pollution control board will give them the authorization. And rule 11 is where the advisory committee, every state government has a its own committee, advisory committee, under the chairmanship of the health secretary, to oversee the implementation of the rule and to advise any type of the if it is needed. So rule 12 is again about the monitoring and implementation it in the healthcare facilities. And rule 13 is the annual report, which I am telling. So it is 30th June of every year. We have to submit in the form 4 before 30th June, and prescribed authority will be sending it to the CPCB, that is the Central Pollution Control Board, on before 31st July of every year. So this is how it has been made, mandatorily made to submit it right in the cutoffs are already given. And rule 14, all the maintenance, so that is regarding the record keeping of this biomedical waste. So every authorized person shall keep and maintain the waste related, biomedical waste related document related to generation, collection, reception, and transportation, treatment, disposal in any other forms of handling of biomedical waste for a period of minimum of 5 years. Okay, so if you are not if you are not retaining it for the period of 5 years, they may give you a notice if they come to you and verify your records. Rule 15 comes is about the accident reporting. So in case in many major accidents, so major accident which occurs, basically it occurs to the handlers of the biomedical waste, and they are our attendant class of staff, or the class 4 type of the staff, those who are handling it. So most important thing is that we should record this incident, which is very important. So incidents recording and reporting is very important. It should not be, they should not be threatened that if they inform any type of the accident or incident, they will be punished. No, not like that. They should be encouraged to do the incident reporting, because if they are most common one is the sharp injury which happens while handling this waste. And it has to be reported within the 24 hours in writing in the with the corrective and preventive action and remedial step in the form 1. So if they are in a fear, they will not be reporting it, and what will happen, they will not be able to get the correct post exposure prophylaxis measure, which is mandatorily required to prevent their healthcare infection in these type of the staff. Rule 16 is any person aggrieved by the order made by the prescribed authority, they can fill a appeal form to the Secretary of Environment of the state government or the union territory. And rule 17 is about the selection of the common biomedical. So this is not so much applicable to particularly to a hospital, because now to prevent the air pollution, and nowadays the many of the state, they are giving a CCA certificate, that is the consolidated consent and authorization, wherein they are taking care of the air pollution as well as the water pollution also. So to prevent all this within the 75-kilometer of the radius, a single common biomedical waste treatment plant can take care of many of the hospitals. So liability 18 is the liability of the occupier and the operator of the facility. Occupier and operator of a common biomedical waste treatment facility shall be liable for all the damages to the environment. So it is more talking about incinerator, its the generation of the toxic and toxic pollutant and gases which is released in the environment. So time to time they need to get checked their this incinerator status, and also the quality of the air which is released into the environment. Otherwise their license can be cancelled. So this is also licensed by the pollution control board. And if any violation is there, then it is liable to the liable to the punishment. So its applicability, as we all know, who generate, collect, receive, stores and transport, treats and dispose the bio or handles the biomedical waste. So mostly it is applicable to the hospitals, clinics, nursing home, and even the small dispensaries, the veterinary institutions, animal house, blood banks, lab. Apart from this, like clinical establishment, this uh, research organization, forensic lab, research lab. It is also applicable to the health camp, medical surgical camps, Ayush hospitals, and vaccination camps and the blood donation camp. So therein you may have a question in your mind that how they will be complying to these biomedical waste management rule while handling a huge camp. Therein we only have to remember only one mantra, that is the mantra of segregation. And that as per the other arrangement to run that camp we are doing, we need to do the arrangement to segregate the waste right at the site of generation. So there are certain keywords. I will not go into. This is all the rules you can download from the internet, and this is very clearly written. So authorized person means occupier and the operator. Biomedical waste, I have already described its definition. Biological prescribed authority, major accident, operator of a common biomedical waste treatment facility. So duties of occupier is to, biomedical waste is supposed to be handled without any loopholes into it, with abiding to all its steps. And we cannot violate any of the steps of necessary steps of the biomedical waste management, so that it doesn't adversely affect the human health and the environment. Making a provision within the premises for the local storage, that is called as a temporary storage area. So it is the hospital authorities is supposed to make a temporary storage area wherein they can store it, the waste, in a color coded manner. In the same manner we are segregating it in our various wards and the department, same way here also you need to segregate. It should be safe, well ventilated and secured. And it doesn't mean that we have made a temporary storage area. It is absolutely temporary. From the temporary storage area, from the generation way of waste to the final disposal of the waste, that means you are sending the waste to the common biomedical waste treatment facility, till that part it should not go beyond 48 hours. So that shows that we cannot store the biomedical waste more than 24 hours in our premises. No secondary handling should be there, pilferages. Previously I don't have those photographs of our own hospital or government settings wherein rack pickers were there was a tendency to throw down the waste from a big in a big corner, from the big youth side window. They will be throwing it down, and the rat pickers are staying waiting for these waste to be dumped in that area, and they will be reusing it. So those days were gone now, and right now it is the scenario has changed. A lot of development in our own country we are seeing, in terms of the healthcare facility infrastructure, as well as to the legal liability of the biomedical waste management. So it shall be from there, it shall be directly transported to the biomedical waste treatment facility. And now they have decided to phase out the chlorinated plastic bags and the blood bags. So we have all those who are coming from the small healthcare setting. Previously they used to push 1% sodium hypochlorite in the blood bags. These days are gone now. They need to pre-treat it. They cannot push a lot of chlorine inside. It has got all. So chlorine being toxic chemical, maybe these so chloride and all aldehydes, uh, this disinfectant we are getting rid of it. So we are more robust system we are adopting. So pre-treat, one important thing is to pre-treat the laboratory waste, microbiological waste and the blood sample and the blood bags. It can be through the disinfection or the sterilization on site. Previously, it was as per NACO guideline, people were, pushing in 1% sodium hypochlorite. But in the 2016, it is written, in the 2019, 2018 and 2019, the WHO Blue Book has come, and Blue Book has clearly mentioned that the laboratory waste, microbiological waste, and blood bags and all, we need to, pre-treat by pre-treated by autoclaving it. Not to give the treated biomedical waste to the municipal solid waste. So dispose all the solid waste other than the biomedical waste. So these are very, very important thing. Now when we talk about the Swachh Bharat Abhiyan, we will see that the similar color coded bins are there. In the biomedical waste, there is again a blue, and in the Swachh Bharat also there is a blue and green. So important fact we need to remember that for the solid waste, municipal waste generation, the dry waste will go into the blue colored bin, and it is a bin. It is not at all a puncture proof, tamper proof container. It is bin. It is not meant for the sharps. Okay. So, and it doesn't have the biohazard symbol on it. And most importantly, you train all your staff to, when you are foot operated bins and these small containers for segregation of the sharps, needle and the glassware sharps, when you are keeping in your hospital, along with the municipal solid waste, the green and the this blue containers, there we need to understand, we need to separate them physically apart, so there is no mixing of these waste. And training, because we cannot retain the staff for a longer period. All the staff now, everywhere, every government setting, every corporate setting, they are working on the principle of the outsourcing of the staff. And once you outsource them, contractual staff, there are whenever they get a good chance, good opportunity, they will leave your organization. So we need a training. And it is, when you train your staff, it is our moral duty to tell them that this training is not only to segregate the biomedical waste in an appropriate manner, but this training is basically a training for their own occupational safety. So with this concept you need to train them, because if they don't segregate and dispose the biomedical waste appropriately, it is more hazardous to their health than a environmental hazard. So this you need to make them understand. And the number of the personnel not undergone any training, so it is mandatorily to train them once every year. So management at the generator, so we segregate as per the color coded bins, and primary disinfection, mutilation, and this we do. Then we pack all the material in the color coded bin, preferably in a non chlorinated plastic bags, and then put the label and maintain the record in a register at the site of generation, and then again at the site of common site of the temporary storage area. And the legal compliances are to the healthcare organization units is to first is to get the legal license to generate it and renew it from time to time, and fill up the annual report every year before 30th June, and transportation it to the common biomedical waste treatment facility in a dedicated vehicle as per biomedical rules, the site for the final disposal. So these are, I think, the category of the biomedical waste has already been, I think, assigned to someone else. Yes. Your session has already been taken on the 6th of May on this categories of the biomedical waste by Dr. Chandra Babu sir. So I'm not going into the detail of it. Okay, so yellow is anatomical. It will directly go for the incineration. Then comes the expired medicine. They will also come in the yellow. Then chemical waste, chemical liquid waste, microbiological waste are also. So yellow is more dangerous. So we don't, treat it also. We directly burn it. So that is the concept. Again, here also, like blood bags and all will go into the yellow. And then comes the contaminated waste, recyclable waste from disposable items like the IV sets, catheter bags, fixed needle with the syringes, they will all go into the red bag. And here we that common biomedical waste treatment facility, they will autoclave it. From the hospital side, you need not to, you need to tie when it is 3/4 filled. You need to take its it is now mandatory also to upload the quantity of the waste you have generated at your website. Okay, and the biomedical waste biohazard stickers, along with the along with barcoded stickers, you need to you need to ask your common biomedical waste treatment facility to provide, so that it can be when you read the barcode, it can be directly uploaded into your systems. Sharp waste, all metal sharp will go into the white puncture proof container. And here we are not burning the needle, but we are having a manual needle cutter which is already attached to it. So it will cut the not the needle, it will cut the hub. So the needle will drop inside this box, puncture proof box. Once it is 3/4 filled, you can lock it and you cannot reopen it, and it will go directly. The most important concept is that it will go to encapsulation in a cement concrete, and this metal can be used later on by the metallurgy. So that's why this, we are not mixing the two variety of the sharp, that is the needle sharp or metal sharp, and the non-metallic sharp, that is the glassware sharp. Glassware sharps and the body implants, they will all go into the blue puncture proof tamper proof containers, and this will be molten, and later on they can be reused. These molten glass can be reused. One important rule is the schedule 2 for the biomedical waste management rule, that is the standard for the emissions. So a common biomedical waste treatment facility shall follow. They are definitely having within a 75 kilometer, they will only have the incinerator, the double chambered incinerator, and they should follow the standard for emissions. The emission standards for the disposal by the plasma pyrolysis and autoclaving by the biomedical waste, microwaving, and the efficacy of the chemical disinfection and the dry heat sterilization. Most important, the liquid waste management, later on it will come in your session. There are standards also for the liquid waste, and wherein all the effluent which is generated or treated from the occupier, and it is coming into the common sewer line, before discharge it should conform to these limits. This can be tested at many of the areas. These can be tested by the pollution control board itself, or a hospital and healthcare. If it is a small hospital, it's okay if they don't have the ETP plant. But if it is a big hospital, they should have a ETP and the STP plant for the liquid waste management. So effluent, the chemical which you are releasing from the CSSD department and the lab, will go into the effluent treatment plant. And once in a as per the state pollution control board, every monthly or quarterly, depending upon their parameters, you need to check for these parameters, are they within the permissible limits or not. Okay, so like pH, BOD, COD, survival assay, all these will be done. The sludge from the effluent treatment plant will go for shall be given to the CBWTF for the incineration, and to the hazardous waste management, waste treatment, storage, disposal facility for the disposal. Okay, so this is what is a schedule 3. This is schedule 4. Schedule 4, all the biomedical waste containers should have the biohazard symbol. One change is there: when you are generating, like in the cancer care centers, they will be using the cytotoxic drugs, okay, the chemotherapeutic drugs, and these all drugs, they should have a label of the C along with this, and it will go in the yellow. And all these important waste quantity, waste number, sender's name, address, phone number, contact person number, emergency contact person number, these all should be the part of these bags. Okay, and day, month, and the date, year, and the date of generation. Packaging from your ward level, you can same way you can pack it so that you don't have any confusion. You can maintain online registers. Are nowadays people are making it a part of the HMIS system. Online system is also there, but if you don't have anything, you please maintain a register so that you don't miss any of the waste generated from any corner of your hospital or healthcare organization. Date of production, place, and waste category. This is the common biomedical waste treatment. Sorry, this is a temporary waste storage area. So this red and yellow is the only this green and blue is the it is a municipal waste, and red and yellow is only the biomedical waste. This is the even the doors are also color coded so that there is no confusion. You can see the photograph of lying here is the weighing machine, so that because this entire business of the common biomedical waste treatment facility lies on its weight per kilogram they will charge you. So once they are charging you per kilogram, they may make fool of you and charging you more. So it's better that you ask them, you get a calibrated weighing machine, and you weigh your biomedical waste for a day when they come to you category wise. And then you even our sanitary inspector and those who have come to collect the biomedical waste for the CBWTF, they shall be writing after weighing it. So this is how a hand washing area is also needed, and segregation of the biomedical waste at the site of. So this is how. So transport vehicle is having a, it cannot be it should have a two chamber vehicle. So it should never be a one chamber vehicle. So the chamber in which the personnel are sitting should be absolutely separate from the chamber in which the waste has been taken, and waste has to be taken again as per the segregation. Okay, so there also the color coding has to be followed. So this is form 1, this is form 2, this is form 3, this is the annual report form. And so the amendment in this rule, initially in 16 March 2018, again the amendment came. And the major amendment which came, previously the glassware shop were supposed to be discarded into the cardboard boxes. But when they were autoclaved or pre-treated, when they are treated at the final disposal site, it was not possible to treat them appropriately. So puncture proof, tamper proof boxes came. And also the laboratory waste, we need to make it more safe. WHO blue book is supposed to be followed and then thereafter sent. So laboratory and blood bank waste, the nari this NACO guideline superseded by the WHO blue book 2014 for the incineration guideline. Major thing which came into the major change which came, it was, I think it was by mistake written 10% of sodium hypochlorite. So if you are pre-treating anything with 10%, now it came to a range, because we get the hypochlorite solution in a range only. So 1 to 2% is substituted. In 2019, again a change came. So like, the for discharge of the biomedical waste or into the public sewer, liquid waste into the public sewer, you need to notify them, and healthcare facility less than 10 bed also need to have the STP by 31st December. But somehow it has, this issue has been resolved, and the pollution control board are working on it, and they are going to the areas where it is, they're going to the sites where it is mixed with the common sewer, and from there they are testing it for its as per schedule 3 which we learned. And if it is within the limit, then it is absolutely fine. So this all came, and we all know that biomedical waste management is not only our ethical and moral responsibility, it is also our legal liability. So if you don't follow this, you can get notice, closure, jail, and fine. And this is what. So I think, sir, I have completed my first session. If am I audible?
Yes, ma'am.
Hello.
Yes, ma'am.
Yeah. So I think the other topic is also absolutely, in connection to this topic only. So shall I finish my presentation and then take up the question answer?
No, ma'am. Thank you.
Hello? Hello?
Yes, ma'am. Yes, ma'am.
Okay, so what I'll do, I will share the other presentation also. You will find it little different and more interesting, because you all are waiting, you all are, working in a hospital and healthcare settings, and it will be, interesting to learn, and biomedical waste itself is a part of it. So, and then we will be taking up all the question and answers. Okay. So I'm going to my next presentation. Yeah, my slides are visible. Hello?
Yes, ma'am.
Hello?
Yes,
Okay,
ma'am.
fine. So I will start my session. So our next important topic, which is very much related to the biomedical waste, and in CSCWM, it is incorporated with the agenda and with, the entire logic that it is not only the waste, it is the infection prevention and control, which will help to reduce the transmission of the infection. So today we'll be learning about the infection prevention and control, methodology which we can adopt in our hospital, and what is the infection prevention, and so comprehensively as a practitioner, what we can do and follow in our organization. So when we talk about the healthcare organization, we are, very much, uh, we are clubbed and surrounded by all the multi-drug resistant organisms. Now this is what is the current scenario. So what is a healthcare associated infection? It is basically an infection which occurs during the process of healthcare in any of the hospital, any of the facility wherein it was not present. And we say it was not present means at that time it was not also incubating. So if an infection has to be stamped as a healthcare associated infection, we say that minimum time period, the cutoff time period from the date of admission, it is supposed to be 48 hours. Okay. So it was previously called as nosocomial, hospital acquired, hospital infection. Now it is called as healthcare associated. So we cannot say that because of hospital is acquired. We say that it is associated to the healthcare setting. So we have changed the name. So it also include the occupational infections, which is among the healthcare providers. To understand this entire healthcare associated infection, we need to understand a very important triangle, which is called as a epidemiological triad. So this triad, this triad has three angles. or three corners, we can say. One is the host, second is the agent, and third is the environment. So the host, there are, so when the infection occur, we all say that there are many factor in the, like for everyone, like we are working in a hospital every day, we don't catch infection. So like for everyone, there are certain factor which prevent us, or certain factor which predispose us to infection. So these host factor can be the age, the nutritional status, the comorbidity, the severity of the diseases. Second comes, if there is no agent, no infection, like no bacteria, no virus, no fungus, definitely no infection. So these variety of the organisms which infect us are the agent factors. They have become very, very smart. So nowadays, we have got not only the infection which are, not only the agent gets the host gets the infection, but they also get the infection which become untreatable, which is called as a multi-drug resistant organism infection, or extended drug organism infection, or we also say them as the non-treatable sort of the infection. Okay, so this is how it is nowadays named. And it's all our, these are all because we have not paid attention to our settings, our environment, and it has happened. So they can be institutional, they can be human, they can be from the reservoir. Environmental factors are very, very importantly the hospital's environment itself. There are all chances that if you are sitting in a home, you will not be infected more, or you will not be catching other infection. If you are admitted in a hospital, definitely the location also matter, the immunosuppressive drug, the chemotherapeutic drugs, the antibiotics, the devices which you put, like catheterize the patient, central line of the patient, exposure to the infected patient, to healthcare worker. And there are many unknown carriers, or we can say the silent carriers, and they are us only, the healthcare workers. So the most common way of getting the healthcare associated infection is through the asymptomatic carrier, and it is the cross infection which is most prevalent. So now, looking to this triangle, what is our important duty to do is to basically break this triangle, or break this chain of transmission of infection. So more and more people life will be saved. So this is the burden. So here, India, you can see orange and even the red one. So red is talking about the pediatric population. So, healthcare associated infection burden is too much. It is said that 7 to 10% of every hospitalized patient is getting healthcare associated infection, and 7 in high income and 10 in the low income and middle income countries. One in four patient gets a healthcare associated infection in the long term and the long term settings, and one in three gets it in the ICU. So this is what is the current scenario. So why this is important? We all know that it is important. The red line you read, the bottom line for this is the most important bottom line for this is, these infections can never become zero, but this infection is preventable. So this fact we need to understand. And understanding this fact, we can, implement the infection prevention and control measures, which will be protecting us, and mainly it will be reducing the transmission of infection and preventing the patient from, or the community from getting infected. So here is, this is the chain of transmission of infection, and our role is to break it down. So infectious agent, you rapidly diagnose it, accurately diagnose it, use the correct antibiotic, or any the treatment. Reservoirs we need to clean. So the reservoirs are our, we say it as a fomite. So any inanimate object is becomes the reservoir for the infection. So we need to daily disinfect all the areas, critical areas, even the knobs of the door, and all these all are, one person touch, the other person comes and touch, and infected from non-infected, it get become infected. Portal of entry, portal, the proper attire is needed. This, you can prevent the infection from getting entered into the host by wearing a proper surgical scrub, proper scrubbing you can do, disinfecting the area like waste, biomedical waste disposal, and control of the excretion and secretion. Transmission you can definitely by hand hygiene. So 70% of the infection, it is said that it is prevented by the proper diligent hand hygiene practices. Then portal of exit, all your patient might be on the catheter wound, they will be having secreting some of the things. It can by aerosol modes or other mode it can get transmitted to other patients, so that portal of exit also we need to break. And susceptible host, we need to treat the underlying causes. So this is how we can try to prevent the healthcare associated infection. We need to develop an infection prevention and control plan, which is a very smart plan. So surveillance, monitoring and auditing, antibiotic policy, reporting and isolation of disease, including the outbreak management, and then training of the, and importantly, very importantly, the health of the staff. Okay. So, to implement an infection prevention and control program, we need to have, first and foremost, it is said that what you do, you document, and what you document is only said to be done. So, we need to have a documented IPC program, which we say as an infection prevention and control manual of any of the hospital. You can, the IPC manual of the Government of India has been released in the year 2020, and it is already published and released. It is in the open domain. You can follow that also. But it is a tailor-made thing, because all the things will not be applicable to you. Your hospital can be a different type of the organization. So, you can make it as per your requirements. Okay, so it is said that you prepare an infection prevention and control program, document a manual, and then every yearly, as per the mm, changes or updates, you also review it and update it. Okay, we need to identify the high risk areas and high risk activity, because this is will be the focus area to prevent the infection and to manage the infection in our settings. So all the high risk activities are the blood body fluids, biomedical waste, aerosol generating procedure. Like if you are intubating a patient you are opening in a OT, the labor room patient, they are all high risk activities. Okay. So review it once a year. I have already told you. And there is one tool which is called as an infection prevention and control program, which is reviewed on the base of CDC and the WHO. If you put it, IFCAP tool, it is called as a IFCAP tool. If you put it in the Google, a 16-page or 17-page document will come. And herein, out of 800 marks, you have to score. And then you will come to know where are you lying. So this is called as a risk assessment. It is called as a baseline assessment of the infection prevention and control. And then you can, develop and improve. So to run and to implement this infection prevention and control program, you need to have a multidisciplinary committee. So who can be the members of this committee? This committee's members can be a hospital administrator. Mainly in our hospital, I am from a government setting, mainly the medical superintendent is the chairman of this committee. Being a microbiologist, we are the member secretary of this committee to give them certain technical guidelines. Infection control specialist, surgeon, infection control officer, infection control nurse. All infection control is not only the responsibility of the infection control nurse and infection control officer, it is everyone's responsibility. Okay, the way we said that biomedical waste generation and its management is everyone's responsibility, same way IPC practices are everyone's responsibility. Okay, so there are those who are involved in the direct patient care and indirect patient care, everyone. So support services also becomes a part of the security staff, the housekeeping staff, the CSSD staff, the OT staff, the nursing, they are in the direct patient care, they all are involved into it. So to lay down, so this meeting, and it is said that you set some of your goals and review it every month, and frequency of the meeting, it is said, has to be at least monthly, and minimum we can write, you can have the quorum. So, and also very importantly, you first circulate the agenda of the meeting well in advance to every member, and then they will come, join, discuss, and you again you have to circulate the minutes of meeting to all those who have attended the meeting. So infection control team is there. So this committee, the big shots are there in the committee. So they will not go to the ward level and the implement the IPC practices. To implement the IPC practices, you need to have the infection control team who can be the part of it. So very importantly, it is said that at a minimum you should have an infection control officer and nurse. Definitely your sanitary inspector, your nursing head, your CSSD person, your security in charge, they can be the part of it. Okay, and day to day functioning and surveillance activities, they will only look. They will be so well trained that later on they will be able to detect the outbreaks and participate in all the day to day audit activities of the infection control team. So here it is, a footnote is written that committee and team should not be seen. Okay, but team can be put as a part of representation in the committee. So you have to have a separate team and separate committee. Designated infection control officer, designated infection control nurse per 250 bed, one ICN is needed, and say she will be doing the compliance monitoring to hand hygiene, transmission based precaution, isolation based precaution, infection specific bundles, sterilization, disinfections, and all she will be looking into. All educational activities, also outbreak management is also a part of it, infection prevention and control. Very importantly, you can't run any of the program if you don't have available resources to do that. If I talk about the hand hygiene, and if I don't have a hand if I have a hand wash station also, but water is not coming, then how can the hand hygiene practices be implemented? So you have to provide all the resources, that is the man and the material, and in a continuable sustainable manner by the management. It should be provided. Allocate a fund so that it is in a sustainable manner. Adequate resources means all the personal protective equipment is the part of the IPC program, needs to be there. Gloves, protective goggles, mask, apron, gown, boot, shoe cover, cap, and all. Okay. Adequate facility has to be there in all patient care area. You need to have a hand wash facility with a large wash basin, hands-free tap. Hands-free tap means it's not like that you are washing hand and again making it dirty. So the elbow operated tap, the soap, liquid soap. It is nowadays it is not recommended to use the solid soap because the wet surface itself become the broth for the microorganisms to grow. So there the microorganism will definitely grow. Okay. So hand rub facilities, install dispensers near, and the last step of this hand hygiene is the drying. So facility for drying also, you can provide the tissue paper, you can provide the dryer, you can provide the towels also, but towels with the multiple use, it is not so effective. So it is very important thing. Then the isolation and the barrier nursing, wherein you all know that for tuberculosis is the big example. COVID is the big example of isolation precaution, because it was airborne infection, so you cannot place them in a common pool in the open wards. Okay, so these all areas, and there the display should be proper, that this is the isolation room. You should not go without wearing the personal protective equipment. It is a negative pressure room like this. Okay, so this all facility has to be created. In COVID we all have created the negative pressure rooms by putting the vacuum and suctions over there. The organization should standard precaution all the time. So the standard precaution starts only with the hand hygiene. Okay, so whatever, any organization, any healthcare worker, when they enter a healthcare organization, the first thing they should do is the hand hygiene. So change the clothes, and so this is the nursing protocols. They change their clothes, they come into the their dress codes and their uniform, and then they will wash the hand. So washing the hand and then wearing all the personal protective equipment. So, adhering to the national and international guidelines of the hand hygiene is a mandatory thing. And, we should not forget any moment, these five moments, which is scientifically given by the WHO. So, before touching the patient, after touching the patient, then before any aseptic procedure, like going for a surgery, doing any procedure on the patient, after blood and body fluid exposure, while you are doing anything, you got exposed to this, and after touching the patient surrounding. So, this five number, the after touching the patient surrounding, patient locker, patient bed, that is very casual of all of us to forget. So, after all these five moments of the hand hygiene needs to be followed. Then hand hygiene, hand washing with the soap and water, alcohol based rub, and the in the surgery it is called as a scrub. This hand hygiene has to go for 60 second if it is 60 second to 90 second if it is a hand wash, and 40 to 60 second if it is a hand rub. And there are the seven moments of the hand hygiene. So these actual seven moments of the hand hygiene we need to do in such a manner this that entire your entire hand is washed appropriately in a time frame of 90 to 180 seconds, mean 1.5 minutes time you need to give. Okay, 1.5 minutes to 2 minutes time you need to give for washing your hands. And then then drying is also very very important. This is a surgical hand wash, wherein it is not called as a hand wash, it is a scrub. Here we are scrubbing all our skin so that even the skin bacteria does not come in contact while we are, because the procedure which we are doing is a invasive procedure where we are breaching the skin, breaching the continuity of the skin. We are putting an incision, so there are all chances that in the major organ or inside any of the any of the cavity, the organism may go and grow inside and do the infection. So then comes the transmission based precaution. It depends upon the type of the transmission which is happening. So can be the airborne, droplet, and the contact. So appropriate PPE we have to wear. And for the contact precaution, definitely you should not be touching the patient. Airborne and droplet, we will be wearing the N95, and the isolation rooms we can use. Then comes the safe injection and safe infusion practices. The entire funda is one needle, one syringe, and only one time. So, reuse of the needle is not at all advocated. Okay. Reuse, recap, these all are not advocated. Then comes the antimicrobial uses policy. So, antibiotic policy a hospital should have with the help of their microbiology department. They should have an antibiogram developed. And so, here I would like to comment that we can have an antibiotic for the antibiotic policy. The standard treatment guidelines are already released in the year 2023 by the ICMR, and it is Android based uh, app they have made. So you can go through it. For all the infectious disease they have given a very good antibiotic policy based on our national antibiograms. Okay, so this we need to do. Then we need to also follow it. Not only we need to document, we need to follow it. Okay, so monitoring the rational use of antibiotic. So very importantly, all the antibiotic, the entire list of the antibiotics like meropenem, vancomycin, it should not be used inadvertently. Like in every and any patient you are giving these high end antibiotics, so there should be some restrictions and monitoring on it. Okay, then comes the engineering control. Hospital engineering control plays an important role in setting up your ward, in making your OTs. In any of the patient care area, 1 to 2 meter spacing between the bed is needed, and designing the operating room wherein we are having a air handling unit. Okay, and their AC plant, AC duct, the HEPA filters. So this is all the part of the engineering. Even the water management and water supply is also supply of the water, quality of the water testing is also the part of the engineering control. Okay, while we are doing the construction and renovation, again we need to do a risk assessment. So, we need to do a surveillance. So, CDC has given a very good guideline, a validated tool for the infection control risk assessment, that is called as ICRA tool. Okay, so how dangerous it is, depending upon the type of the activity. If you are doing a minor repair work, your you will barricade that area and you will do it. If it is a major repair work, you will definitely be shutting down the wards and do a major renovation. The nearby transmission you need to prevent. So that risk we do assess, and then we use the optimal control measures for that. Okay, housekeeping department, you should never forget. If we are implementing the IPC practices, a hospital cannot survive without a housekeeping department. And so categorically here also, depending upon the risk, we categorize their activity, and we categorize, depending upon the risk, the areas of the hospital into the critical, semi-critical, and non-critical area. And depending upon that, we determine their frequency of cleaning. So Kayakalp guidelines and Swachh Bharat guidelines are very good guidelines to be referred to prepare your own housekeeping guidelines. Okay, and it is the minimum mandatory requirement. And then if you see that if area is already exposed, like in ICU, exposed to the body fluid, that time only you need to clean it again. Biomedical waste management, we have already seen. The linen and laundry is also part of it. If there is if you don't use a good quality linen and a clean linen, there are all chances of getting infection and bed sore into the patient. Okay, so this is very important. So changing of linen is very, very important. Getting the infected linen disinfected and then send it to most of the facilities are having the linen as a outsource. you know uh, they are having a linen as a outsource facility. Okay, so it's our duty to go and visit these. I forgot to tell you in the biomedical waste also, and here also I am repeating it. Any of the outsource agency, we need to check them with their service parameter, whether we have made an MOU and are they serving it optimally or not. So for common biomedical waste treatment facility, a hospital visit twice a year is mandatory. You go there, make your checklist and see are they following all the guidelines and criteria. Same way is for the linen, same way is for the kitchen also. Okay, so this we need to do. Even government of India has released 7-day color coded linen. That is a very good concept of preventing the healthcare associated infection. Then comes the kitchen sanitation and the food handling. If you are having your own kitchen, we need to give a good quality and non-infected food to the, because most important source of infection is the food itself. If a food is stale, spoiled, dirty, not served in a hygienic way, there are all chances of getting a food poisoning, and all they become the source of outbreak. Okay, if you are having your own kitchen, it's absolutely fine. If you are not having your own kitchen, again it is not it is absolutely it is fine, but you need to visit those also. The kitchen staff or handlers should be you know visiting handlers should be vaccinated, and their health checkup is very mandatory. It is their vaccination to the, not only to the hepatitis B, but also to the typhoid vaccination. Okay, so they should be screened for the as a typhoid carrier and ova and cyst carrier. These all we need to do. So this is kitchen sanitation. Then comes the healthcare associated infection monitoring. So how do we monitor? So there are very important there are only, see, each and every infection we cannot monitor and do the surveillance of it. So there are 4 indicator disease or healthcare associated infection which we need to monitor, and as per CDC guideline, globally it is followed. So this is 3 are the device associated and 1 is the procedure associated. So first one is the catheter associated urinary tract infection, because we say that if catheter is there, catheter is attributable cause for the infection. Same way, if the central line is there, central line is the attributable cause of the infection. If patient is on ventilator, this ventilation has made him more prone to the infection. Okay, and fourth one is the procedure, that is a surgery. I have already told you we are putting a breach in the continuity of the skin, so patient become more prone to the infection. So these are only four disease indicator. These are all called as HAI indicators, healthcare associated infection indicators. Okay, HAIs, they are the defined HAI which we need to monitor. So most important thing is, we need to adhere to the basic principle of the prevention, that is a standard precaution and transmission, and we need to develop a bundle of care, a bundle of activities where we can prevent this infection. So the care bundles you can develop for the ventilator associated pneumonia, catheter associated urinary tract infection, same way the central line associated, and same way for the surgical, that is the pre-op, intra-op, and the post-op. Okay, and then comes the surveillance of the infection. So data verification. In the surveillance, we also need to do the monitoring of the compliance of the hand hygiene. So I already told you the 5 moments of the hand hygiene. If you google into the WHO hand hygiene compliance, they have got a very good tool, and which is revolving around the 5 moments of the hand hygiene. And herein it will be capturing that while working, during their work hours, they have got 10, for example, I am giving 10 opportunities to wash their hand, but they didn't did it. Okay, so in how many opportunities they did it, and in how many opportunities they did it in a correct manner. Okay, so that is very very important. So these compliance, you can not, it should not a punitive act, it is only a audit for improvement. So you will be as per category of the staff, you'll be saying, you'll not be saying that doctor this has not washed the hand properly, doctor nurse that has not done. No, it is on category. You can narrow it down up to the floor and ward, but you cannot name them, because once you start naming it, it becomes a blame game and they will not be following it. Okay, so it is, we need to monitor it, and we need to give the feedback of all our monitoring. So HAI rates, the adherence rate, everything we need to give it to the ground level staff, those who are actually working. Then only the changes will happen. Most important is then comes the outbreak investigation. So early detection is very very important. So as per time, place, and person, we need to do the case definition, and we need to found all the causes, and we need to break the chain of transmission in the outbreak investigation. Then comes the central sterile supply department. So sterilization activity, so very importantly, it is called as the five-star kitchen of a hospital. It is providing all the recipes and all the crockeries to the operation theater. Okay, so we all know that without getting a sterile environment, there are all chances of patient getting infected by after the operation. So central sterile supply department will make all the equipment sterile, and then only it will supply. There is a concept of zoning over here. So what happens if you are designing a central sterile supply department? First and foremost is your, if it is not decentralized, from the operation theater the use instrument will come, and that is a dirty area, there it will come for the cleaning. There you clean it properly, put it enzyme cleaner, and put it in the washer disinfector, and scrub it appropriately, and you wash it properly so that all blood, body fluid, and all organic material has gone, and then it goes to the drying area. Then comes, it will come to a clean area where you will after drying you will pack it, and then it will be put into the machine. The packaging standards are also different when we are putting into the different type of the sterilization mode. Like for the steam sterilization, we use the muslin clothes. For the this ETO and the plasma sterilization, we are using the Tyvek papers. So this we need to take care. And then comes the sterile area, that is a storage area. So receiving of the instrument will happen in the cleaning area, and issue will happen from the store area. Okay, and in between this soiled, clean, and sterile zone, there will be a barrier. It is said that sterile zone is a positive pressure ventilation. Okay, so the Spalding's classification is applicable to it. So, when we are dealing with the instrument, if it is not critical, you can use the disinfectant low level, like for the BP instrument and oximeter and all. If it is going to your mucus, like any of the scopes, it is a semi critical high level disinfection, it's better to use the sterilization. And third is the critical, if it is going to your major body vessels, okay, major body cavity, body vessels, then including the blood contact, then it has to be sterile. Okay, so this is what is CSSD. When you do all this activity, we need to validate our activities. So it's very important to put the controls. So there are the chemical disinfection, biological, chemical indicator and the biological indicator we are using with the each load and batch, and then we are releasing it. If it is so, like physical, chemical, so chemical indicators are used daily. Physical indicators, you need to record the time, temperature, pressure every day. Then chemical are the strips and biological are the weekly. Okay, so Bovidic and engineering validations are also there, so that we need to do. Okay, breakdown in the sterilization system, that is called as recall. If these indicators are fail, it is absolute breakdown. So we will recall all the batch we have released, and we will not and then we will use the backup machine for again re-sterilizing it. And we will open the batch, and then we'll see what was the problem, and then we will repack it again and put it in the another machine. And by the time we will repair this machine which has gone to the breakdown. And then the staff health, occupational health is also the part of IPC program. So adequate resources, standard precaution, pre-employment health checkup is very important. Immunization is important, and capturing their immunization status is also important. In the immunization policy, you can immunize at least for hepatitis B, tetanus, toxoid, and the COVID. We all had been immunized to, depending upon the exposure. Like in the kitchen staff, you need to go for the hepatitis A vaccine, and also the this typhoid vaccination. Okay, so this policy we can define. And we can have a work restriction policy, wherein all our infected staff, they can be given some desktop work, or they should not be going in direct contact. Like patient of the chickenpox, acute respiratory infection, conjunctivitis, should be refrain from that activity for some time till they are recovered. And do not penalize them, otherwise they will not work for you. Then comes the post-exposure prophylaxis. If you get a needle stick injury or blood and body fluid exposure, as per the NACO guidelines, you are supposed to do the post-exposure prophylaxis. So after that, so for hepatitis B, we have vaccination available, and PEP immunoglobulins also. Hepatitis HIV, we have the ART, antiretroviral therapy, which is available, and record of all the PEP given. So this is in toto the IPC program, and implementation of the IPC program, the monitoring of the IPC program. And as a healthcare professional, what is our role is to break the chain of transmission of infection. So that's it from my side, and thank you so much. So now I am done with my presentation. Stop sharing. Yeah, very good afternoon to all of you. Any, Dr. Tripathi, any question and answer we can take up now, sir? Hello?
Yes. Now we can take up questions from the students.
Yes, sir.
So students are now requested to kindly put their questions if there is any, or if they want to make any comments or suggestions or any views also, they can make it, because we all you all are experts in different fields. So if you have any anything new that which you can share with your friends, you can do so. There is absolutely no issue.
There is already a one question is who makes the incident report. So basically, it was, I think, in link with the previous session, that is was the biomedical waste management. But the incident reporting for the infection prevention and control practice or biomedical waste management, which is also a part of IPC program, has to be reported to the infection control nurse. So she should be your nodal person to whom you should report, and she should be filling the form depending upon the type of the incident which has happened. Okay.
Any other question, please? Poonam Madam, Ravi Kiran, Kailash Bania, Josna Pavan, Megha. So please come forward if you have anything to ask, any question to ask.
So, sir, they can, I think, if they are not having any questions, they can, all the recommended literature they can read, and later on they can email it to Kuba madam and to you also,
Yes, yes.
that we can resolve their queries.
But before that, I would like to tell the students that we have uploaded the recordings of different classes that we have conducted in the past in YouTube channel and in IGNO's website also. And I think we have also sent all those the links of all those videos to all the students, isn't it? You can also watch those videos in your leisure time, so that you will get to know about many new information, new knowledge from the presentations of the experts. So it will be useful for you.
So I would like to tell them that they should visit the AIMS site for HAI monitoring. The AIMS is running in the country the healthcare associated infection monitoring entire program. We are also the part of it. So from there, a lot of open material is there in the open domain. They can refer to it. Second important is the NCDC, that is a National Center for Diseases Control. Their site also the IPC manual, that is a National Healthcare Prevention of Healthcare Infection. They will be, that is already loaded over there, IPC in healthcare facility. Okay, so this is the national program, national document which is available free of cost. They can download it and refer to. And I have already told them that for ICMR standard treatment guidelines for antibiotic policy, the app has been made. It is not for the Apple phone, but for the Android phone, they have made an app. So they can download later on, maybe when I get time, I may share it to you and Kuba madam, so that they can, open it and read all the material.
It will be
So
It will be wonderful, madam. Please send us to us so that we will share with the students, and
surely, sir.
all those things will certainly be useful to them.
Sure, sir. So if there are no questions, sir, can we close it?
Two, three more things that I would like to share with the students. One thing is about the workshop. So many students are asking, me also and to different regional centers also, about conduct of workshop for the CHCWM program. So dear students, I would like to tell you that workshop will be conducted somewhere around July or something, because Madam Ruchika Kuba was telling that after the examination, June term and examination, she is planning to conduct the workshop. And the workshop will be conducted online, so you need not have to worry at all. Once the schedule is prepared by School of Health Sciences, the same will be circulated among all of you, and you can attend those workshops. And but before that, you have to complete the pre-workshop activities. There are two things: pre-workshop activities and post-workshop activities. Okay, so these two reports you are supposed to submit at your respective region. Last time Madam said it should be sent to Maulana Azad Medical College, Delhi. But this time, I cannot say. It is up to the Director School of Health Sciences. So once it is decided, then you have to send these workshop reports also to the concerned destination so that will be evaluated. Okay. And the project, and the second part is your project. You have to undertake a small project as per the project manual supplied to you. Please read the project manual and see how it is supposed to be conducted at different settings, isn't it? Healthcare settings. And accordingly, prepare that project report and submit that project report for evaluation. There is no viva voce for that. It will only be evaluated by the experts, and the marks will be sent to students evaluation division for incorporation in your grade card. So pre-workshop activities, post-workshop activities, and project report. These three things are supposed to be submitted. So please remember, and from today itself, please plan how you will, undertake all those activities at your respective, healthcare settings. Okay. And regarding assignments, you all know. Please start writing the assignments and submit the assignments also at your respective regional center, either study center. If you're attached to the study center, submit it. Otherwise, the concerned regional center is the best place for submission of assignments, which will be subsequently evaluated. So take care of all those things and start reading so that you can appear the June term and examination and complete the program. So this is all, madam, I wanted to say. I think if there is nothing else to discuss for today's session, then we should call it a day.
Yes, sir. Yes, sir. Thank you, each and every participant. Thank you, sir, for coordinating it. Thank you very much.
So thank you very much, madam. So to
you.
you also, because you have taken a lot of pain in speaking to the students on various important aspects which are really useful. And I also thank all the students who are present today, actively participated, listened to you, because whatever we are doing for their benefit. So this is all for today, and we'll be meeting on 9th, that means tomorrow, with some new topic by some new resource person. So till such time, we take leave of you. Thank you very much, all of you.
Thank you, sir. Thank you. Thank you.